We're incredibly lucky tonight to have Seok Lim, who is the head of the Royal Melbourne Hospital in the Home program. She's a geriatrician by training and heads, as I said, RMH at Home, which is a 45-bed really acute care substitution service, which covers patients at home and patients in residential care and shared facilities. She is very interested in exploring and defining patient cohorts that are best suited to hospital in the home care and utilising technology to augment and bridge the gap between hospital and the home. And she was really a leader in COVID-19 hospital in the home care in Victoria. And we'll hear some very interesting stuff about her program. Thank you so much.
Thanks. Hi, everyone. Thanks, Ben. So I'm going to talk about COVID-19 and other respiratory viruses in adults, and then we have another session on pediatric care subsequently. So I head the RMH at Home acute unit. As you see here, we are part of the RMH at Home family, which also includes the rehab and geriatric rehabilitation at home units and residential inreach, which is an ED outreach to residential aged care facilities service, which is relevant to COVID, as I'll cover shortly. The service itself works on an acute hospital ward bed substitution model. We are part of the Royal Melbourne Hospital, administratively under the Medicine and Community Care Division and the General Medicine Department, just like Ben at Monash. It's a mix of HITH bed card and joint HITH or specialty bed card patients. And that implies, I guess, there's some patients where clinical governance and responsibilities lie solely within HITH. And these patients often have what we call general medical issues with pneumonia, heart failure, AKI, cellulitis, UTIs, pyelonephritis. And then there's other patients with issues like requiring longer-term antibiotics, such as endocarditis, the MAC infections was spoken about, bronchiectasis, as previously mentioned a couple of months ago, chemotherapy, delivery for patients with malignancies, anticoagulant management, complex wounds, and perioperative care. Overall, we have about 130 discharges a month with a median length of stay of 5.6 days. The team consists of 3 physician consultants, 1 geriatric medicine advanced trainee, and 2 basic physician trainees with a part-time HMO. And this, I guess, really provides a daily, weekday and weekend facility to provide medical and nursing home visits, hospital-based reviews, and telehealth reviews to patients. There's a pharmacist within the unit, and the nursing staff within the unit work from 7 a.m. to 9:30 p.m. daily, and that helps us facilitate twice daily home visits, which are sometimes necessary. So this orange thing here is a map of Australia. And within Australia, I'm from Victoria. And within Victoria, I'm from Melbourne, which is that red circle you see over there. And within Melbourne, I guess that the 2 red hedges is where my hospital is located. The red weird looking thing there is the catchment area of patients covered by my HITH service, which is roughly 25% of the land area of metropolitan Melbourne itself. I'm not quite sure whether I'm happy or sad. I'm probably overall sad to be in the position of talking about COVID care to you, to the group here this evening. And I guess I'm talking about COVID care because, unfortunately, overall, Victoria's ended up with 71% of COVID cases across Australia. And where I live and work, the West Metro cluster has ended up with 53% of Victorian COVID, Victorian COVID cases across 2020 and a little bit of 2021. And in Victoria, we've had 90% of the Australian COVID deaths. And I guess really that's why I'm here this evening, because we happen to have I happen to live and work in a region where there were a lot of people with COVID. So this is a graph of the case rates of COVID in Victoria from February 2020 to March 2021, which is very similar to the case rates in Victoria. And what you see here, I guess the blue and the gray bits is the cases where there is community transmission, so acquired in Australia, as opposed to being acquired overseas and detected in hotel quarantine. And we had a large part of these cases here in the West Metropolitan region. This is the rough, this is, I guess, some publicly available information about the age range of patients with COVID in Victoria and in the West Metropolitan Cluster. And most of the patients really were in the age ranges between 20 to 30 and 20 to 50. And then a slightly smaller group which was associated with high morbidity and mortality in the over 70, over 18, over 90 years old. This is a infographic of all the local government areas in Victoria, of which there's 79. And all I can point out is to say that the bits which are squared off in black there are my 9 local government areas. And together, altogether, I guess it's kind of bad that I can find all 9 of them in this infographic here by name. And that's because we looked after half of the cases there. So what did we do? We had a couple of COVID-19 programs. I thought that, I guess, COVID-19 really is a viral respiratory illness, and it would probably act like other viral respiratory illnesses out there, like the flu. And I know it's not the flu, but I guess if you think about provision of care and development of a model of care, then it's not a bad comparison to make. So we felt that we could look after anybody who's unwell with confirmed COVID-19, who is clinically stable enough for home-based care, or really wanted to stay at home with COVID, and that might include dying at home. But I guess the secondary or the other equally important consideration to make with COVID is that the home environment where the person is staying needs to be safe to other people, either to their care providers or to other people they live with. So they must be able to self-isolate, or they must not be able to pose an infectious risk to other people. And so particularly in residential aged care facilities, infection control and transmission prevention principles will need to be assessed in our model of care. We didn't want to take anyone who didn't want to be cared for at home, obviously. And what did we provide to them? So we provide standard, I guess what we call standard HITH. So 24/7 telephone access to hospital staff, daylight access to in-person nursing and medical staffing, delivery of medications that can be delivered at home. So fluids, antibiotics, oxygen, Clexane, and investigative resources such as venipuncture, so blood tests. We were unable to deliver X-ray or ultrasound on site. Usually we could have, but these 2 investigations required equipment which would subsequently have some infection control or infection transmission consequences. The staff obviously needed to be provided with PPE and trained to use PPE appropriately. And we also supplemented our model of care with telehealth consultations. So staff needed to be upskilled in terms of providing, in terms of ability to assess patients via telehealth. And then from the patient's point of view, we also provided, for suitable patients, we provided home monitoring devices, so oximeter, thermometer, and for patients who don't have access to a smartphone or a laptop with an internet, we provided a tablet and SIM card to them. So our ethos was that these patients would be cared for within the HITH bed card, so we had clinical governance over them. The care plan needed to be jointly derived between the patients and their doctor because we required their co-participation in many cases. And we included care, and we kind of recognized, I guess, that we had pre-existing, before COVID, we've always looked after a very frail cohort who wanted to receive care in their home or in their aged care home. So we wanted to we didn't want to forget about this cohort. And so we said, right, if COVID reaches the residential aged care facilities, we would then care for them as well, the way we've always done. And it takes into account, some goals of care, predetermined goals of care at point of admission about escalation pathways, what they wanted to receive as part of their medical care, and some prognostication about what might happen as part of the COVID-19 disease. So and then, moving on from the goals of care, really, we said, we'll look after people with COVID with the aim of either recovering from the acute illness or palliation in the event that cure is unachievable. So we had a virtual arm, and then we had an in-person, or what we call standard HITH care arm. So overall, we had 3 teams in HITH during the second wave. So there's the virtual COVID arm, the standard COVID HITH arm, and then the non-COVID HITH team. The virtual COVID HITH arm included, I guess, people who had an in-home assessment at points of admission for the physical examination and investigations. And then subsequently, they had twice daily telehealth assessment with oximetry and heart rate measurement at rest and at exertion. And this required that patients could co-participate in this program with a mobile phone or was internet connected and had moderate COVID symptoms without hypoxia. In the standard COVID HITH arm, we had redeployed geriatricians and geriatric medicine trainee, BPTs, and HITH and our residential in-reach nurses who delivered daily in-person nursing and medical assessments of their symptoms, treatment with oxygen, often subcutaneous fluids in the setting of delirium and nausea, and medications, plus minus end-of-life care if necessary. For people in a shared residential facility, then that also required some thinking around the infection prevention or transmission prevention principles. So this included liaison with the residential aged care staff and the public health unit about appropriate outbreak management in the facility, and to deploy this model of care, we had we drew up some staff PPE guidelines because we recognized that sometimes it was very difficult for staff to be changing PPE in between patients, for example, in an environment which had many people with COVID, and essentially we had staff change PPE at about the 3.5 hour mark. Non-COVID HITH team really delivered unusual non-COVID care with the daily in-person nursing or medical assessments of symptoms. I guess this is some two photos sort of illustrating what we did. So that's on the right-hand side here. You'd see a sort of nursing home environment, and on the left-hand side is kind of an example of what our virtual COVID arm looked like. The escalation process for patients within our unit involved a telephone assessment by the doctor and then an subsequent organization of hospital transfer if appropriate, with referral to either alternate accommodation if infection control was a problem, so hotel quarantine, private hospital sometimes, in-hospital management, or the emergency department for further investigations. So this is kind of a workflow where we receive referrals to and what happened to patients. So we had GPs refer to us, and this is through the cluster COVID positive pathway, which I'll go on in my next slide. We had hospital teams refer to us from either the emergency department, the COVID ward as part of step-down care, or the staff support program, which was run by the hospital wellbeing team for staff who had COVID. And then we also received referrals from our residential in-reach team who maintained an ED outreach service to diagnostically swab patients with symptoms of COVID. And then subsequently, then they were either treated within the virtual arm or the standard care arm with PPE. Overall, we had, let's say, about 250 patients thereabouts last year. So 148 within the virtual arm, and then 113 patients, most of them being residents of aged care facilities, with 31 having deceased in our service and 8 discharged with plans for end-of-life care. I'm going to move on to talk briefly about where our model of care sits within our region, so the West Metropolitan COVID positive, and this pathway, which is called the West Metropolitan COVID positive pathway. It's a collaboration between our local primary health network, primary care, and four our local hospital health services with hospitals within the region, and the Department of Health, which and two units, I guess, within the Department of Health, the public health unit and the virtual care unit. And the idea was that we wanted to deliver wraparound clinical and psychosocial care to all COVID positive people in our Western Metropolitan cluster, regardless of how they were diagnosed. So regardless of whether they were diagnosed through ED, diagnosed by a GP, or diagnosed by a self-referred drive-through testing service. We just wanted to know all about them if they lived in our region, and make sure that they were all receiving appropriate care. This is I guess a pictorial of the pathway. So essentially wherever someone got tested, we would then have all the information. And the problem here, I guess, really at the bulk of the second wave was, it's really hard to tell who was positive, because if someone self-referred themselves, they the GP wouldn't know about it, the hospital health service wouldn't know about it, and the only people who would know about it was the public health unit, who would then deliver the notification call. We first then said, all right, well, other than notifying someone that they have COVID, other than doing contact tracing and, and telling them to call the coronavirus hotline, we also wanted to triage, identify people who were at low risk or medium risk or high risk for severe COVID. And with the idea that people with low risk of severe COVID, low risk of developing severe COVID had a proactive GP telehealth contact. People with medium risk or moderate symptoms had hospital-based outreach care, for example, by hospital in the home. And then people who were really, really sick went into hospital. To deliver this pathway, we needed to develop a shared patient record so that everyone knew which stream of care someone was in at the same time. And development of this entire pathway really required collaboration between the primary health network to coordinate and educate GPs, the hospital services, and the Department of Health. So this is a rough illustration of the different types of home-based care, home-based monitoring that was delivered by the pathway. So GPs would proactively contact someone every second day. HITH would see them every day, and there was a bit of a middle arm where you'd have someone from the hospital call you every day. And the difference, I guess, between GP and outpatient care was that we recognized that a lot of GP services did not operate a 7-day service. So for people who require a 7-day telephone outreach service, they would then be conducted by the hospital health services outpatient-based telehealth care. And I guess really, did it work? I guess it did, because our numbers are pretty low at the moment in Melbourne and Victoria. Why did it work? I think it's as been raised previously in this forum earlier this evening. There's really about collaboration between lots of people. And collaboration here for protection of our community, and it required collaboration between clinical care providers, but also social and welfare supports. And we needed to make sure that, in terms of sharing data from everyone, we needed a policy, legal, and technical framework to kind of be able to do that. And so there was a technical team, a clinical team, and a governance team, which collaborated from every organization, which worked together to address these issues. And it really wouldn't have worked if there was, no pandemic payment, or there's no JobKeeper or job seeker payment. We needed someone to kind of make sure people were getting groceries so that they could self-isolate at home and not running out to 7-Eleven, for example. So my conclusions, I guess, from last year, and some notes about where 2021 and where HITH might be going subsequently is, again, it wouldn't have happened without this sort of initial engagement with one local area, the primary health network to coordinate GPs, and then subsequent involvement of the other 3 cluster health services. And it also certainly required patient co-participation to be at home and participate in the telehealth assessments. We found out that the majority of people could and wanted to be cared for by their own GP, but this needed to take into account the variable nature of private practices and the timings of care delivery that could be done by a private GP practice. And it wouldn't have worked without a coordinating body, which was the primary health network in our case. We use technology in the sense of using telehealth and using home monitoring devices, but we didn't let the technology lead assessments of humans. There was always a human clinician behind the assessment. So for what next? Where are we now? So I guess for 2021, we want to continue delivering this type of wraparound clinical and psychosocial supports, because we feel that's effective for people with COVID-19 in order to support home-based isolation. This requires an ongoing sharing of data and information between the public health unit, GPs, and hospital health services. But now then, looking at these sort of principles that we've learned, we're looking at its applicability to its other illnesses and other situations. So is this the same for heart failure? Is this the same for type 2 diabetes? can we use hospital in the home for other situations based on these sorts of principles?
You really have summarized what was a year of incredibly hard work into a few slides. It's really amazing to hear about your program.